All right, so chapter 14 is about sensory diseases or disorders in the elderly. All right, so let's talk about, some visual system stuff. First, you have low vision. This is loss of sight that is not correctable with ordinary lenses, and it causes, dysfunction. Any kind of thing with vision automatically causes a dysfunction in ADLs. So estimated that 3.5 million individuals in the United States have low vision, and 80% of them are over 65. So would you consider low vision a normal part of aging? We talked about that. Yep. Low vision is considered kind of normal. That gradual loss of vision it's part of normal aging. It just happens. Low vision implies that there is some remaining sight for the person. So when you see something like a diagnosis of low vision on somebody, it doesn't mean that they're blind, right? It's just low vision, and it can be to different degrees. Legally, blindness is vision of 2200 or less, even with vision correction. Okay, so if you see a diagnosis on somebody's chart that says that they're legally blind, that's what it means. Now, does it mean that they have no sight at all? Somebody's legally blind? No. What's the difference? Maggie, what's the difference with legally blind versus like total blindness? Right. That's always the way I remember it. Somebody's legally blind, they're not driving. Right. Now there's other factors there, but that's what comes to me. Like they can still see, just not well enough that they're able to drive. Right. All right. So let's talk about cataracts. Has anybody, most everybody has met somebody with cataracts or talked to them and how they have this miracle surgery when they cut them off. My God, they can see again. Cataracts are 9 times out of 10 are correctable. They have hazy and blurred vision, lots of difficulty driving at night. In fact, most people with cataracts don't drive at night because they feel so unsafe, unless they really have no choice. The surgery is where they go in and kind of cut the lens off and replace it. They can do glasses, stuff like that, but 9 times out of 10 is the surgical intervention is what people go with because it's a permanent fix. We've talked a lot about age-related macular degeneration. I don't feel like we need to rehash that, but macular degeneration, again, is the loss of the central vision, which is what? Where's your central vision, guys?
Middle.
Yes. It's right here, in the middle. Everything in the middle. Maybe we do need to rehash macular degeneration. All right, so there's glaucoma. Again, we don't really need to rehash the causes and all of that. It's the same in elderly people as it is, anyone else. So it's a result. The loss is in the peripheral vision, which is what? The sides. Everything on the sides. All right. I want to show you guys this video. I forgot I even had this one saved, but I really like this demonstration. And if somebody would like to make these glasses, I would almost offer bonus points.
Almost?
I would.
How much?
I'd offer 5 bonus points if you wanted to make it.
I've got a blank out piece of visual field, but typical of somebody that has advanced glaucoma. There's someone with glaucoma, parts of their vision appear blurry. It's not blacked out completely, but it's as if there's a whitish film around it, or just parts of their vision are missing. So this is 2 examples of visual field defects that people may have with glaucoma. You can see that the white patches here, if you look through this pair of glasses, should appear quite blurry, but not necessarily black.
So, oh, well, crap. How aggravating would it be to try to drive like that? I mean, it would be impossible, right? And then the scary part is that there is people that have no choice. They still drive like this. How terrifying, right?
But not necessarily black. there are different patterns of visual field loss. Usually it begins from the outside in with the central vision the last bit to go, but unfortunately sometimes with glaucoma the visual field defects can go straight across the center of the visual field early. You can have different sorts of patterns in different eyes. With this sort of visual field defect in advanced glaucoma, you would not be able to drive a car. You would have very poor depth perception, and your chances of falling down a flight of stairs are pretty good.
How difficult is that? Just even going upstairs.
This is extremely different from what we used to. My field of vision is extremely restricted, and it's quite disorientating. This is difficult to understand where things will see where things are. This is very difficult. I certainly wouldn't want to have to deal with this on a daily basis.
Did you notice something that he had to do to like correct it? What was he doing or compensate for? Right, he had to move his head all over the place to try to even look at a computer screen, right?
My first impression of the glaucoma glasses are that it's pretty annoying. I have to go through this folder and find the piece of paper with the X on it. I hope it's not up there because I can't see that. Oh, here you go. It's exciting. That's surprisingly hard.
So even something like searching through papers trying to find a document, how difficult would that be? There's a wonderful Wi-Fi, but I think you guys get the gist of it, right? All right. All right, so diabetic retinopathy, remember this is something that happens when somebody has diabetes.
If I had glaucoma, it would be very challenging to find sports.
All right, so secondary to diabetes, it gets worse with long-term uncontrolled disease. If somebody has had diabetes for a while and they're unaware, their doctor didn't catch it, or it went a while without being treated, diabetic retinopathy can be much, much worse for patients, or they can get it much sooner. It leads to spotty vision, and it ultimately will lead to blindness if the patient lives, long enough that they don't have any other health issues. There are some visual deficits that are related to Parkinson's and Alzheimer's disease. You have Parkinsonian retinopathy. It creates visual problems that include hallucinations, problems with reading, attention, and diminished contrast sensitivity. So without even going into the Alzheimer's, what is the major area that OT is probably concerned about? Safety, right. We're automatically concerned about safety. If somebody has Parkinson's disease, we know what are some physical characteristics that we automatically are looking at. Lindsay, what are some physical things that you see? Balance is terrible, right? Like that shuffling gait. Okay. Faith, what are some other things that you see with Parkinson's disease? The tremors, absolutely. So far we've already named off two that create a big safety issue for what? Safety issue for falling. A safety issue for safety. That's right. Safety. A safety issue for falling, right? So now you throw in, we've already named two that are really, really big. They have tremors, they have that shuffling gait, and then you add on top of it that they have some type of a hallucination. Don't think of like, somebody standing in the back of the room that's not really there. It's not what I'm going at. What if they think there's an extra step, or they hallucinate there's an extra step, or there is a step and there is no step? Those kind of things. A good friend of mine, who his dad just passed away from Parkinson's disease, and he had falls all the time, and that was mainly because the shuffling gait, and that he would think that there's an extra step or whatever. He couldn't plan his stuff because he couldn't see correctly. Alzheimer's leads to visuospatial deficits that appear primarily with reading, problems with discriminating form and color. All these different issues. When you start treating somebody with Alzheimer's disease, they may appear at a different stage in Alzheimer's, but they have these visual issues that's actually causing them to not be able to function at a higher level. So you need to be aware of what's actually causing the issue. Just because somebody has Alzheimer's, it might not mean that they're, in the later stages. They might be in one of the earlier stages, but they're starting to experience these visual issues, and that creates a big safety issue. All right, so intervention for vision loss. Interdisciplinary intervention is the most effective form, which means what? What is interdisciplinary interventions? Jennifer, what is interdisciplinary interventions? Exactly, interventions that involve other disciplines. So having their eye doctor involved in their treatment. If you notice something and they're not going to regular eye doctor visits, and you see these deficits they need to be in their doctor's office like yesterday, getting them involved. What about the family members? They can be, a discipline in themselves. I mean, not exactly a medical discipline, but they're going to notice things a lot more than you will because you're there they're there with them the majority of the time. Physical therapy, speech therapy, all these different disciplines out there need to be involved with treatment because everybody's going to see something a little bit different, right? Visual impairment can affect all areas of function. I need to change it from saying most to all because I can't even think of an area that if you had low vision that it wouldn't impair. And if there's a cognitive impairment on top of it, that really complicates things, right? If you're not just treating low vision, you're treating low vision with Alzheimer's disease. You got to figure out what is causing the issue. What is the big fall risk? Is it because they can't see? Is it because they have poor balance? What's the issue? All right, so what are some roles that we're going to do? First, educate the older adult family members and caregivers about low vision. So education right off the bat. Teach the older adult how to use devices in ADLs. So basically those first two right there was pretty much what y'all's practical was, right? Education and teaching how to use devices with ADLs. I think everybody pretty much at this point has those two aspects of OT down, which is exactly where we expected you guys to be. That's why we're pushing you now to expand, come up with something completely original, right? Next, assist the older adult to develop appropriate adaptive techniques to expand their visual and physical capabilities. That is now stepping into this next practical, right? You're teaching them a new way to do things, not just this piece of equipment that can help them do stuff. You're going to teach them a comp strategy, something you can come up with. It doesn't have to be straight out of the textbook. Next, educate about comp strategies like environmental modifications. That's huge. Hey, add some light. Hey, add a poster in their vision of safety that is, more in their central. Don't put it over here on this wall. If they're laying in bed, have the poster directly in front of them, somewhere where they're going to see it, right? Addressed any psychosocial issues. That's expanding into more of your final practical that we're going to be looking at. And then refer the older adult to community services. That's that idea we talked about a lot last semester, that knowing your resources, knowing the community around you, seeing if there is a help group for caregivers with dealing with patients with low vision or Alzheimer's or Parkinson's or whatever it be. Here's some really cool interventions. This is just, I want you guys to be getting familiar. Now, this is more equipment. This is just a electronic magnifying glass. They're pretty common. You get them on Amazon. I think they're like $20, $30. This is one of my favorite interventions. What do you think this helps? Why do you think this is beneficial for somebody? There's too many buttons. Why would you do that? Right, you're limiting choices. I mean, how many times, even when you get a brand new remote, like you switch TVs or TV providers, it takes you a little while to learn the remote, right? Now throw in low vision, now throw in some kind of a cognitive impairment and say, okay, use this brand new remote. How difficult does that make it for somebody, right? So what this does, it's just a piece of paper that they cut and put around it, cut out where the buttons are that they need to know, and taped it on the back and wrote directions on it too. I love this. I think this is one of the coolest inventions. What is this? What is special about that? It's color coded. Huh? And large. It's big. How often or how helpful is it for, somebody with a busy schedule who may have a lot of doctor's appointments to have a big space where they can write their appointments on a calendar, right? What does the color coding do? What does that help them with? What does color coding help you with? Huh? Knowing what is what, okay? So this is addressing multiple areas. Low vision. It's addressing a cognitive impairment. What else? Think of all the areas that just a large calendar with color coding can help you. Just organization, right? Just organization in general, remembering appointments. Even if it just, okay, red means it's bingo night. That's huge. One of the first things when a speech therapist, love her to death, she's one of the best ones I've ever met, would come into our facility, the very first thing she would do is give them a large print calendar. That was the very first thing she did. Okay, what do you do on Thursdays? Okay, let's write that on here in this color. What do you do on Tuesdays? Write it in this color. And she would help them get organized. What that does for somebody is, first, it keeps them organized. Second, it gives them choice, and they're in control of their therapy session, right? They're deciding what they're working on. You're helping them get organized. You're helping them, live their daily life. You're hitting all of your goals, but you're also letting them run the session. It was genius. I absolutely loved it. She carried these large print calendars with her everywhere she went. She had her whole trunk was full of them all the time. And I thought it was just awesome. All right, so let's talk about some vestibular system stuff. Does anybody have any questions so far? Good. A lot of it was review, but starting to think more on the intervention side of it. So as far as vestibular disorders, if there's any kind there's going to be a fall risk. One of the most common is vertigo. My mom has vertigo. When she gets old, we're really in for it because her balance sucks already. So we'll see. But when you see any kind of a vestibular system disorder, the first thing I want you guys to think of is balance. Okay. Auditory. You guys remember the tendonitis video I showed you? What is it? It's that constant, it could be high pitch, could be buzzing. It's just noise in your ear and how aggravating it is. Why is that a safety issue? Maggie, why is that a safety issue? Okay, that's a little more extreme. Yeah, they could for sure. Faith, why is tendonitis a safety issue? Okay, why? A distraction. What about like hearing a siren to get over, for an ambulance or a police car or anything like that, or hearing somebody blow a horn or anything? When you talk to patients who have tendonitis, they say that often that's the only thing they can focus on. So when you said distracting, that's right up, exactly what I'm going at is it's so overwhelming for some people that they can't focus on anything else. It doesn't matter what intervention that you try to teach them, they can't focus and learn it because they're so focused on that noise. So one intervention is music. A lot of times patients, if they can get their focus off of that and something that's not as aggravating, as a constant like buzzing noise, maybe play their favorite music, keep it on play. That's a good intervention. Okay. Um, Oftentimes you'll have patients that already have hearing aids. I did want to mention this, but they don't want to wear them because they're not comfortable. So if you get a patient who can't hear you, it's a safety risk. But they have hearing aids, they won't wear them. How do you address that, Isaiah? It's a little difficult, huh? Why aren't they comfortable? You start asking, why don't you wear them? They say, oh, they're not comfortable. Why are they not comfortable? Okay, next step, what would you do, Allie? I don't wear them because they're not comfortable. Okay, it's okay if you don't know. What'd you do, Lindsay? I don't wear my hearing aids because they're not comfortable. How do you respond to me?
I just feel like I would be like, well, that's your decision. Like, you know what I mean? Like, old people are only going to change so much. They're only going to
You're
change
right.
their decisions.
You're absolutely
So I
right.
would be like, well, you can either hear me or you can't.
Okay. Cassidy, what do you do? First thing you can talk about, or give them a handout because they're not going to hear you when you talk about it. What about like, okay, can you wear it just during our session? Start out small. They try wearing it about 30 minutes at a time because a lot of doctors, they prescribe these hearing aids. They get them, they don't like them, they're uncomfortable, they feel embarrassed by them, whatever the issue may be. And you can just start out slow with them and say, hey, wear it during, at church on Sunday. Wear it during your favorite program on Thursday nights, those kind of things. You don't want to miss out on those things. Here's the benefits of it. Try wearing it a little bit at a time and working your way up. That's that wearing schedule stuff. See how we talked about a lot of wearing schedule stuff with splints, and splint, we're always worried about there being comfortable, skin irritation, all this stuff. There's the same issues with a hearing aid. A lot of people don't like them because they're not comfortable. They don't want people to see them wearing it. It rubs a little sore on the back of their ear. They're not used to stuff like that. So having them wear it a little bit at a time, building up that tolerance, is a huge help. Okay? Pathology of the skin. You guys pretty much know this stuff. We reviewed it in 207. I didn't want to, touch on it again unless you guys, do you have any questions about any of this stuff? The only semi-new one is the pruritus, and that's just excessive itching. Okay. All right, let's talk about.
Suggest like lotion.
It depends. Everybody has lotion. You're not going to say, I'm going to prescribe you this special lotion, but, rarely does somebody have anything. I can't even think one off the top of my head where they can't have lotion. Like even when you go into a nursing home or facility, what do they give you in your care package? A toothbrush, toothpaste, socks, a water basin, and lotion. Everyone gets lotion and a comb. So, lotion's not really a medication. Now, you don't want to go out and say, okay, I want you to get this one because this one, like go off dermatology on them. But if they have some Gold Bond and they have some itchy skin, have you tried putting any lotion on it? And go about it that way. Okay. All right. So let's talk about pain. I have talked about pain 1,000 times now in this course or in this program. Pain with older adults, I'm starting to see it different. The old generation can really, really tolerate some pain. I've had 80, 90-year-old ladies who, I've had to do some range of motion on them on a frozen shoulder, and they take it like a champ. They're in a lot of pain, and they are, but they take it like a champ. But I'm starting to see these 50 and 60-year-olds frozen shoulders and try to do range of motion with them, and they can't take it. They just simply can't. Why do you think that's changing? Why do you think older adults, like our current generation of older adults, is being able to tolerate pain better than the newly coming older adults? I think, yes, both of those. Cultural expectations, the whole idea of no pain, no gain. And then a lot of, today's culture, oh, you have a little bit of soreness in your right shoulder, take an ibuprofen or whatever, right? That's what were taught. A lot of the older generation didn't do that. They couldn't.
I feel like pain wasn't a vital sign before.
Right,
That's
it
what you're
wasn't.
saying.
So why do we ask? That's exactly where I'm going with this. Why do we ask what their pain level is now? I generalize pain, but do we generalize pain in OT? Isaiah? We don't generalize anything. Right, because pain is very what? It's very subjective. Right now I could go and ask Lindsay what her pain is, and she may tell me, we may have gone through the exact same thing, and I perceive the pain as very, very little. You perceive the pain as overwhelming and can't, handle it. But I will say, in my experience, that old adults are able to tolerate pain a lot better than a lot of people. And they kind of shrug it off as, hey, I want to work this out. I want to get my function back. They'll put the pain aside, but a lot of people can't. So you need to really, those ideas of working with somebody when they've taken their pain medication or scheduling their pain medication around therapy or whatever, those are really good tips and tricks if you're going to get a good treatment session with somebody with a lot of pain. Okay. Anorexia of aging. We normally don't talk about anorexia with aging adults, right? It's kind of a foreign subject. Sometimes it's unintentional. Sometimes it's, they just don't eat a whole lot. How many people know especially older women, that just have a very tiny appetite? They eat very, very little. I always tell, my grandma that she eats like a bird because she eats very, very small portions. But it's a big issue because these are the people that need that nutrition the most. Their body is breaking down. It can't heal itself as well as what somebody who is younger can. And it's very frequent in nursing homes. The reason I think it's so frequent in nursing homes is not only they're at that age where, their appetite and stuff starts to diminish. They can't taste things as well. But the food in nursing homes normally sucks. It's gross. A lot of people don't like the taste of it. I don't know how many times just to get a patient to eat, I have stopped at Tutors on the way into work, got them a biscuit, and had breakfast with them before we did our treatment session that day. Which is okay as long as you are obeying their diet restrictions. You can do stuff like that. If somebody has dementia, there's a lot of cognitive stuff going on that may inhibit them wanting to eat or asking to eat. So it takes somebody who's, paying attention to them and watching their schedule, making sure that they're still getting proper nutrition. Some stuff that we can do with these people is proper seating, giving them time to eat. Often they don't give people time to eat in nursing homes, and that's because they're overworked. I don't blame them. I'm not, screaming bad things about CNAs. I'm just saying they're overworked. They don't have time. They have Ethel over here who takes an hour and a half to eat, a portion of mashed potatoes and green beans, but they can get it done in 10 minutes if they just run over there and feed her. That's not helping anybody. And you have to educate them on that, right? This is where you might even go to your administrators and be like, hey, we need more staff during feeding time, or you need someone dedicated to feed this patient every day that can plan this amount of time because she's not getting any food, or she's losing this ability because we're just constantly feeding her and she doesn't need help feeding. She just needs time. Dental care. A lot of people will stop eating and they won't tell you if they have a toothache or if their dentures are rubbing sores on their gums. I've taken many times, and it's disgusting. I'm sorry, it's part of the job. You get gloves on, take their dentures out, and they just have food caked all in the top of their dentures. It's disgusting, but how would you like to eat like that? If you had yesterday's chopped steak and stuck up in your gums, and then somebody's trying to feed you breakfast, are you going to think it's very appetizing? No, right? So sometimes just cleaning the dentures will change their eating habits altogether. It's amazing how something so small and so, normal and common sense can make such a massive difference. Swallowing exercises if they need them, and then giving them appealing food. About when we went over the food lab, do you guys remember us talking about how they've started to make different textures into the shapes of whatever food is trying to mimic? Remember that, like the molds? where if it was a ground up hamburger, they had a mold of a hamburger and it made it look more appealing. You still are scooping it up with a spoon, but a lot of visual stuff, goes into food being, appetizing. How many times you got something it's all the idea of that subliminal messaging. You see a McDonald's commercial and you see this awesome looking Big Mac and then you get it for real and it looks like crap. You're like, wow, that wasn't nearly as good as what the commercial made me think it was going to be. It's the same thing, but in a smaller scale with older people. Or if somebody's having trouble eating, is if you give them something and it looks gross, they're not going to want to eat it. There's no motivation. 99% of the time, the one constant for older people is ice cream. And as long as they don't have diet restrictions, you can get them to eat ice cream because it looks the same here, there, and everywhere. All right, so some chemosensory changes, diminished olfactory smell and taste, reduced pleasure in food, all of that kind of stuff can contribute to anorexia of aging. If somebody has a long history of smoking, there's a lot of stuff that goes into that. Your taste and smell is diminished with a long history of smoking. Some things that we can do is provide oral care before meals, provide medication and doses that is going to be consistent with mealtime, providing hot meals. That one's huge too. Sometimes it's not even an issue if it looks good. A hamburger pretty much looks like a hamburger everywhere, but if you get one and it's cold, I mean, how many times have you sent your plate back in the restaurant because it either wasn't cooked right or food was cold or whatever? Now we're literally this is the meal that you get, period. You don't get another option. It's sad because a lot of these issues could be solved with just good kitchen staff, or adequate staff in another way. Also giving them food at the highest texture that they can tolerate. Is remember the different textures we guys gave you, is even with the waters. If I had to give you thickened liquids all the time, would you want it? Now, what if I told you were drinking thickened liquids, but you could tolerate thin? That's often, a lot of times orders won't get changed. I've gone into many, many patients' trays and saw that they had thickened milk or thickened water for lunch and they're on thin liquids. Why do you even have that? And that diminishes their nutrition. All things that you have to look at, and then apply flavors by food or flavor enhancers. That's what I was telling you, like barbecue sauce is big with patients. A lot of people keep that ketchup, mustard, salt packets, whatever, right on their bedside table because they don't care what it is. They're putting something on it because they know that will taste good. Some other interventions are provide meals at the time that they are most awake. Breakfast comes in a nursing home normally at 7:30, period. If you're somebody that doesn't wake up till 9:30, 10, they've already picked up the trays and taken them. You missed out on breakfast. How crappy is that? Sometimes your more experienced older CNAs will leave the food in there. If it's like cereal, if they know somebody doesn't wake up till later, they'll leave that food in there or get them something that it's okay if it's cold, like cereal, or keep their milk in the refrigerator or whatever. But nursing homes are good in theory, but there's a lot of things that it's not individual treatment. It is, all right, trays are coming on the floor, send it out to the patients. That's pretty much what, they don't care what time you want to eat. I've always thought that you would have a lot more success as far as nutrition goes if it was a buffet system in nursing homes. You took the patient in, they had no choice but to sit in there and eat at the table in the lunch hall or dining hall or whatever. Okay, you want this today, and give them options. Like, make it a buffet. If you opened up a Golden Corral in a nursing home, you would hit home plate. I mean, that is the proper way to do it. That's the way we want to be treated. I feel like older people should have that same option. Provide transportation and meals to reduce energy expenditure. I always would get my patients and take them to the dining halls if they had deficits in that. Take them there so they're not so tired. Control the volume of food, and then treat any conditions that are causing pain and stress. Some more institutional type practices are encourage choice of dining companions. You may say, they may have a roommate that they really, really like, and that's who they want to sit with at lunch. If I put you guys at a table with a bunch of strangers and asked you to eat your lunch, you may do it, but are you going to enjoy it? But if I put you like right beside your best friend to go out and, have lunch, you're much more likely to eat, right? Identify optimal level of staff. That's again going to your administrators. Avoid using mealtime to distribute medications. Sometimes you can't avoid that. Avoid it if at all possible, but sometimes, somebody has a noon, they like to eat at noon, they have a noon medication, you're supposed to take it with food. Sometimes you can't avoid it. Ensure that the dining room is an inviting environment. I've been in some dining rooms that look like prisons. I mean, legit, they're dark, they're depressing. I mean, they look like someone's basement. And I'm like, this is no wonder nobody wants to eat here and everybody wants to eat in their room. This is terrible. And then it's a calm environment. You can do that sometimes you can't. Sometimes you do have those louder, patients that have dementia or some type of a disorder. That's why they're there. They're loud. Sometimes they're combative. And it can make a huge rush. I've had patients pick up their plate of food and throw it at another patient. So a dining room sometimes cannot be. So what we came up with in my facility was we had two different rooms. We had one room where there was not like a cognitive disability going on. Like they could come in, they were more there for physical rehab, some type of that. And we would have, and they had no assistance. You just handed them food, they could eat, right? Then we had another room where we had the people that, needed more assistance, that sometimes could become combative, often had screams. If there's everybody in that same room is going through the same stuff, it's not abnormal, right? But if you put one person in there that's combative, screaming, all this stuff in a room where, you have this scary little 70-year-old lady who just fell for a broken hip, and that's why she's there, it doesn't mesh well, right? And then again, you want to get all the different disciplines involved. Like a lot of facilities have now hired nutritionists. Some have dentists that come in and out, and we'll see patients. They make their rounds. OT, PT, speech, pharmacists, and healthcare aides. Okay, everybody needs to be aware, especially that last one of healthcare aides. The CNAs, if you can teach them like proper denture care and saying, hey, they're pocketing food up in their dentures. Make sure you take those out every morning before breakfast or at night like they're supposed to, and have them cleaned. All right. Any questions?